Kooyal.
Thank you very much, Deputy Speaker. And I rise today to speak to the amendments to the Higher Education Support Act 2003 in this bill, which provide for demand-driven funding of places in medical schools for First Nations students. Deputy Speaker, this amendment is about equity of education and equity of access to the best possible medical care in this country. It's about removing barriers and it's about planning for Australia's future healthcare needs. Access to best practice medical care should always be available. It should always be culturally appropriate. But too often, patients in First Nations and culturally diverse communities in Australia have experienced language barriers, cultural misunderstandings and, more often than we would like to acknowledge, outright prejudice when they come to access health care. Those services are not safe, and unsafe services are a deterrent to seeking medical assistance, which can lead to negative health outcomes. A diverse medical workforce and the inclusion of First Nations people on the very front line of our medical care will help to build culturally safe services and will improve the standard of care across all of our health professions. I reflect on my own experiences as a paediatric registrar at the Royal Darwin Hospital more than 20 years ago, when I was trying to find common ground with children who'd never been in a building with a lift before, who had never experienced air conditioning, who spoke primarily a First Nations language with which I could not correspond. And I remember how complicated, difficult, challenging and sad it was then to find it really, really difficult to provide best quality, culturally safe health care. And I contrast that with experiences of hearing from and witnessing the amazing work of Dr Jason King, Director of Clinical Services at the Gurindji-Yalumaka Hill Health Service Aboriginal Corporation in Yarrabah last year, when the Parliamentary Health Committee, of which I'm very proud to be a member, visited his community as part of our inquiry into diabetes in this country. In a generation, we have come such a long way, and we are now able to see the extraordinary value and the impact of Indigenous Australians leading multidisciplinary best practice healthcare facilities within their own communities. Aboriginal community-controlled health organisations are possibly the most successful community health organisations in this country. They were founded in response to Indigenous Australians' experiences of racism, let's call it what it is, racism, in primary health care, and their unmet need for culturally safe and accessible services. The model has now been so successful that we have more than 145 ACCHOs delivering holistic, comprehensive, culturally safe primary health care for Aboriginal and Torres Strait Islander peoples nationally. Those services have been shown to improve health outcomes. They've been shown to decrease the cost of care, especially for remote communities. But First Nations doctors are still underrepresented in our medical profession. In 2023, roughly 0.6% of all doctors in Australia identified as Aboriginal or Torres Strait Islander, despite them representing overall 3% of the Australian population. In uncapping places in medical courses for First Nations students, so that all First Nations students who meet the entry requirements to enrol in courses in medicine can be enrolled in a Commonwealth-supported place, this amendment responds to Recommendation 3B of the Australian Universities Accord final report, which recommended that Australian Government provide places for all First Nations students who apply and who meet entry requirements for a position in a medical school. It is worth noting that our medical schools are already trying hard to recruit Indigenous medical students through special entry schemes and quotas, and they have already had some success. 3% of domestic medical students are Indigenous, compared to 2.3% of the overall domestic student population. In fact, the main obstacle to further enrolment increases might actually be in finding the right students, not in the availability or otherwise of training places. I note that the government has budgeted only $560,000 for places under this scheme in 2026-2027. Deputy Speaker, that equates to only about 17 medical equivalent full-time student loads, suggesting that the government itself does not anticipate that this legislation is going to result in a major increase in the number of Indigenous medical students. There's a complication here. Medical degrees are designated courses in our universities. That means that they have a specified number of allocated student places. University funding agreements limit them to specified numbers of domestic medical degree completions, and over-enrolment can actually result in a breach of the university's funding agreements. That means that introducing demand-driven funding for Indigenous medical students will not in itself change the completions cap, which operates independently of designation. So if a university has designated medical places transferred to the estimated Indigenous demand-driven places, but then ends up having fewer commencing Indigenous medical students than anticipated, its actual number of total medical students will actually decline. So given the likely low numbers involved and the low numbers estimated by the government in budgeting for this scheme, I ask the government to ensure that any additional Indigenous medical students will be put into a model of future completions, in which case the cap could be adjusted up. It's a win-win for everybody. It's going to take years to address the inequality in our medical systems, but creating opportunities for them to study medicine is the first step in building an expanded workforce of Indigenous graduates, GPs and specialist doctors to work in the great teaching hospitals of our metropolitan centres, in small private hospitals like those in my electorate of Kooyong, but also in the outros and the outreach services of rural and regional Australia. We know that rural and regional Australia has significant shortages of medical practitioners. Despite the outstanding work of rural nurses and allied health professionals, those shortages result in inequity, which is apparent in the health outcomes experienced by people living in those communities. According to the Australian Institute of Health and Welfare, rural and regional students are more likely to have chronic health conditions and less likely to access healthcare than patients in major cities. While most First Nations people live in urban centres, they do represent a third of the population in remote locations, which are areas which suffered the double disadvantage of increased health risks and lesser health services. Most medical graduates don't want to practice outside a capital city, but over 72% of graduates from rural backgrounds prefer to go home and to practice outside the cities. First Nations doctors are also more likely to choose to practice in ACHOs and in rural, regional and remote communities. So the solution is clear. Barriers to rural and First Nations students must be removed to attract and support the rural doctors of the future. So I urge the Minister for Education to continue this important work, to remove barriers to training and to support First Nations and rural medical graduates. The support should include an increase in designated places for Indigenous students, additional to, not replacing, the places that we have for non-Indigenous students. And I commend this bill to the